Two neighbors, same street, same age. Both turned 53 within months of each other. Both felt fine, as far as they could tell. Neither had any symptoms they considered worth a phone call to their doctor. But one of them had a colonoscopy that year, because her daughter kept asking her to schedule it. The other kept meaning to book one, and never quite got around to it. The woman who had the screening had a polyp removed, small, contained, gone in 12 minutes during the procedure. Her doctor told her it was the kind of polyp that, left another 3 to 5 years, would have become something much harder to treat. She went home that afternoon, had soup for dinner, and did not think about cancer again for several years. The woman who did not get screened was diagnosed with stage 3 colorectal cancer 22 months later. She is alive today, and I am grateful for that. But she spent 14 months in chemotherapy, lost a portion of her colon, and will carry the physical and emotional weight of that diagnosis for the rest of her life. Two neighbors, one decision, a completely different story. And the only thing that separated them was a single screening appointment that one of them kept and one of them didn't. I'm Dr. Alan Miller, and after 18 years in senior health, I've seen what works and what silently harms. And I've watched this exact scenario play out more times than I can count. A cancer found early, treated cleanly, and survived. And a cancer found late because nobody looked soon enough. The difference between those two outcomes is almost never biology. It is almost always timing. And timing, in the world of cancer screening, is something that you control more than you may realize. By the end of this video, you will understand exactly what cancer screening is and why it works so powerfully when it begins at 50. Which specific screenings matter most for adults in your age group and why. What the research actually shows about the difference between early and late detection, in numbers that are impossible to argue with, and what is stopping most adults over 50 from being screened, and how to remove every one of those barriers starting this week. And I need to say something clearly before we go any further, because I know some of you may have heard that cancer screening can cause more harm than good, or that it leads to unnecessary procedures, or that early detection does not always change outcomes. Those concerns deserve a real answer, not a dismissal, and I am going to give them one directly in a few minutes before we are done. Stay with me. First, I want to make sure you understand what we are actually talking about when we talk about cancer screening, because the word gets used so broadly that it can start to feel abstract. Cancer screening is not a diagnosis. It is not a treatment. It is a process of looking for cancer, or for the cellular changes that precede cancer, in a person who has no symptoms. That last part is the critical one. No symptoms. Because the entire premise of screening is built on a biological truth that took decades of research to establish clearly. Cancer is almost always more treatable and more survivable when it is found before it has produced any symptoms at all. Think about what a symptom actually is. A symptom is your body's way of telling you that something has already changed enough to be felt. A lump you can feel, a cough that will not go away, blood where there should not be blood. By the time cancer produces a symptom that a person notices and brings to a doctor, it has almost always been growing for a significant period of time, sometimes years. The cells that eventually become a detectable tumor do not appear overnight. They accumulate mutations slowly, replicate quietly, and in many cases develop an entire local blood supply before they are large enough to produce any external sign at all. Screening looks for cancer before that process completes, before the symptom arrives. When the abnormal cells are still few enough, localized enough, and vulnerable enough that the options for treatment are at their widest, and the outcomes are at their best. This is not a theoretical benefit. The survival data across multiple cancer types is so consistent, so replicated across so many populations and decades of research, that it has become one of the most firmly established principles in modern medicine. And yet, despite that evidence, Fewer than half of all eligible adults over 50 are current with their recommended cancer screenings in the United States. Fewer than half. That number has consequences. Let me show you exactly what those consequences look like in the cancers that affect seniors most directly. Colorectal cancer is the third most commonly diagnosed cancer in both men and women over 50, and it is one of the most preventable. Not just detectable, preventable. This is the distinction that changes everything, and it is why colorectal cancer screening belongs at the center of every conversation about senior health. The colon does not typically produce cancer without first producing something called a polyp, an abnormal growth on the inner lining of the colon wall. Most polyps are benign and cause no harm, but a specific type, called an adenomatous polyp, has the potential to undergo additional cellular changes over time and become cancerous. That process takes years, in many cases between 5 and 15 years, which means there is a window, a long, generous, accessible window, during which a screening colonoscopy can locate that polyp, remove it on the spot, and prevent the cancer from ever forming in the first place. Let me give you the survival numbers, because they are the most compelling argument I know. When colorectal cancer is found at stage 1, meaning it is confined entirely to the inner layer of the colon wall and has not spread, the 5-year survival rate is approximately 90%. At stage 2, still localized but grown more deeply into the colon wall, survival drops to around 70 to 80%. At stage 3, where cancer has reached nearby lymph nodes, survival falls to between 40 and 70%, depending on the extent of spread. And at stage 4, where cancer has metastasized to distant organs, the 5-year survival rate is approximately 14%. 14% versus 90%. That is not a marginal difference. That is the difference between a procedure on a Tuesday afternoon and a 14-month ordeal that reshapes every part of a person's life. And the factor that most reliably determines which of those numbers applies to a given person is how early the cancer was found, which is determined, more than anything else, by whether they were screened. I had a patient named Carol, 57 years old, a high school principal, someone who ran half marathons and took exceptional care of herself in every measurable way. She came to me for a full wellness evaluation, and almost as an afterthought at the end of our appointment, mentioned she had never had a colonoscopy because the preparation process seemed unpleasant, and she had simply never prioritized it. I asked her to prioritize it now. She agreed, somewhat reluctantly. The colonoscopy found 2 adenomatous polyps, both removed during the procedure. Her gastroenterologist told her that one of them, in particular, showed cellular changes consistent with the early stages of a transition toward malignancy. Carol thanked me at her follow-up appointment with a steadiness that told me she understood, fully, what that result meant. She has since told every woman she knows who is over 50 to stop postponing their colonoscopy. She is one of the best advocates I have ever inadvertently created. But colorectal cancer is only one part of this conversation. What comes next applies to every woman over 50 in this audience, and it may be the most important thing you hear today. Breast cancer is the most commonly diagnosed cancer in women, and it is the second leading cause of cancer death in women in the United States. But here is the fact that changes the entire conversation. When breast cancer is detected at its earliest stage, stage 1, before it has spread to lymph nodes or other tissue, the 5-year survival rate exceeds 98%. 98%. That is not a disease that is beating us. That is a disease we are defeating consistently when we find it early enough. Mammography is imperfect. I want to acknowledge that clearly, because dismissing legitimate concerns does not serve you. Mammography produces false positives, results that appear abnormal and require follow-up that ultimately reveals no cancer. False positives cause anxiety, additional procedures, and in some cases biopsies that come back benign. These are real costs. They deserve to be weighed honestly. But they must be weighed against the cost of a missed cancer. And when that calculation is done carefully, using all of the available evidence, the consensus across major medical organizations is clear. For women beginning at 50, regular mammography saves lives at a rate that far outweighs its limitations. The conversation about screening frequency, every year versus every 2 years, is one worth having directly with your doctor, based on your personal risk factors, your family history, and your own values about the trade-offs involved. That is a real conversation, and it deserves a real answer, tailored to you specifically. What is not negotiable, what the evidence does not leave open to reasonable debate, is whether women over 50 should be screened at all. They should. Full stop. I had a patient named Evelyn, 61 years old, a grandmother of 4, and someone who had skipped her last 2 mammograms because she had moved, changed insurance providers, and kept meaning to reestablish care with a new physician. The gap was nearly 4 years by the time she sat in my office. We ordered the mammogram that week. It found a mass. It was stage 1. Evelyn had a lumpectomy, a short course of radiation, and is today, 3 years later, cancer-free. She told me that she had convinced herself during those 4 years that she was probably fine, that nothing was wrong, that she would feel it if something was off. She had not felt anything. And that, she now understands, was never the right standard. For men over 50, the screening conversation centers significantly on prostate cancer, and I want to address it with the nuance it deserves, because this is an area where the guidelines are genuinely more complex. Prostate cancer is the most commonly diagnosed cancer in men, and the second most common cause of cancer death in men. But not all prostate cancers behave the same way. Some are slow-growing, unlikely to spread significantly within a man's natural lifespan, and may be appropriately managed with active surveillance rather than aggressive treatment. Others are aggressive and require prompt intervention. PSA testing, a blood test that measures a protein produced by the prostate gland, is the primary screening tool, and it is imperfect in both directions. It can be elevated for reasons other than cancer, including benign prostate enlargement and infection, and it can miss certain cancers. The current guidance from most major medical organizations recommends that men between 50 and 70 discuss PSA screening with their doctor individually, taking into account their personal risk factors, their family history, and their own values around early detection and the potential for overtreatment. What I want every man watching this to take from that guidance is this: the conversation itself is the screening. If you have not had an explicit, direct conversation with your doctor about PSA testing, about whether it makes sense for you specifically, about what your personal risk profile looks like, then you are not yet making an informed decision. You are simply not deciding. And not deciding in medicine is always a choice with consequences. I promised you a direct answer to the concern that screening sometimes causes more harm than good. Here it is, and it's more nuanced than most people expect. The argument against cancer screening, made at its most honest, goes something like this: screening leads to overdiagnosis, the detection of cancers that would never have caused harm during a person's lifetime, which then leads to overtreatment, exposing patients to surgery, chemotherapy, and radiation for a disease that was never going to kill them. This is a real phenomenon. It is documented in the research literature. It applies most clearly to certain slow-growing prostate cancers and to a subset of thyroid cancers. It is a legitimate concern, and it deserves a legitimate response. The legitimate response is not to abandon screening. It is to have better conversations about what a positive screening result means and what the options are. Active surveillance, careful monitoring of a detected abnormality without immediate intervention, is a medically sound approach for specific cancer types and specific risk profiles. The goal of screening is not to treat everything that is found. The goal is to find everything that needs to be treated early enough that treatment works. Those are different things, and the distinction is one your doctor can help you navigate. What the overdiagnosis argument does not do, what it cannot do when the evidence is examined honestly, is justify not being screened for colorectal cancer, breast cancer in women, lung cancer in current or former heavy smokers, or cervical cancer through regular Pap testing. In these cases, the survival benefit of early detection is so large, and the harm of late detection so severe and so well documented, that the scale does not balance in favor of avoidance. The scale tips clearly and consistently toward screening. Now I want to talk about the barriers. Because if the evidence is this clear, and it is, then why are fewer than half of eligible adults over 50 current with their recommended screenings? The answer is not ignorance, and it is not laziness. The barriers are real, they are specific, and every single one of them is addressable. The first barrier is the preparation. The colonoscopy preparation, the dietary restrictions, and bowel cleansing process the day before the procedure is the most commonly cited reason adults postpone or decline colorectal screening. And I will not pretend it is comfortable. It is not. But I will tell you what I tell every patient who raises this concern. The preparation is one day. One uncomfortable, undignified, manageable day. And the alternative, a cancer found at stage 3 because you postponed for 5 years, is not one day. It is months. I also want you to know that the preparation process has improved significantly over the past decade. Lower volume preparations are now available that reduce the amount of liquid required. Your gastroenterologist can discuss the options with you and find the one that is most tolerable for your specific situation. The second barrier is fear of what might be found. This is the most human barrier on the list, and the one I approach with the most care, because it is rooted in something real. The fear of a cancer diagnosis is rational. Cancer is frightening. The treatment of cancer is frightening. But here is the truth I want you to sit with for a moment. The cancer that exists in your body does not become more treatable by remaining undetected. It becomes less treatable. The fear of finding something is the fear of knowledge, and knowledge in medicine is what opens doors. Not knowing does not close the door on cancer. It closes the door on the options that make the outcome better. I had a patient named Harold, 64 years old, a retired firefighter, someone who had faced genuinely dangerous situations throughout his career without flinching. Harold had been declining his colonoscopy for 7 years, not because he did not understand its importance, because he was afraid of what it might find. His wife finally persuaded him to schedule it by pointing out, with the directness that only 38 years of marriage permits, that she needed him to be here. The colonoscopy found nothing. Harold wept in my office, not from relief, he said, but from the recognition of how much time he had spent carrying a fear that a single appointment could have put to rest years earlier. The third barrier is cost and access. This is the barrier I take most seriously, because it is the one that is not a matter of psychology or perception. It is a structural reality that affects millions of older adults. Here is what you need to know. Under the Affordable Care Act, most health insurance plans, including Medicare, are required to cover recommended cancer screenings with no out-of-pocket cost to the patient when performed by an in-network provider. A screening colonoscopy for adults over 50 is covered by Medicare Part B with no copay and no deductible when it is performed as a preventive screening rather than a diagnostic procedure. Mammograms are covered annually for women over 40 under Medicare Part B. PSA testing is covered for men over 50. If you are uninsured or underinsured, federally qualified health centers provide preventive screenings on a sliding scale fee basis. The National Breast and Cervical Cancer Early Detection Program provides free or low-cost mammograms and cervical cancer screenings to women who qualify based on income. These resources exist. They are real. And if you are uncertain whether your specific screening is covered, a single phone call to your insurance provider or your state's Department of Health can tell you precisely what is available to you. The fourth barrier is simply not having been told. Not clearly, not directly, not in a way that felt personally urgent. This is the barrier that this video is specifically designed to address. Because there is a difference between knowing abstractly that cancer screening is recommended and understanding viscerally, in your chest, in the place where decisions actually get made, why it matters for you, specifically, right now, at this point in your life. Here is what I want you to do before this video ends. 5 steps. Write them down. Step 1. Identify where you stand right now. If you are over 50 and you are not certain when you last had a colonoscopy, a mammogram, or a PSA conversation with your doctor, that uncertainty is your action item. Not next month. This week, call your doctor's office and ask them to review your screening history and tell you what is due. 1 phone call. That is the entire first step. Step 2. Know your family history before your next appointment. If a first-degree relative, a parent, a sibling, was diagnosed with colorectal cancer, breast cancer, ovarian cancer, or prostate cancer, your screening recommendations may be different from the general population. Some high-risk individuals are advised to begin screening at 40 rather than 50, and to screen more frequently. Write down the specific cancers in your family history, the relatives who were affected, and the ages at which they were diagnosed, and bring that information to your next appointment. It directly shapes the conversation your doctor will have with you. Step 3. Schedule the appointment before you leave today, not someday, today, or tomorrow at the latest. Not because urgency is a manipulation, but because the research on health behavior is unambiguous. The gap between intention and action in preventive health is bridged by specificity. Not, I will schedule a colonoscopy soon, a date, a time, a confirmation number. The decision you make in the next 24 hours is statistically more likely to become the appointment you actually keep than the decision you plan to make next month. Step 4. Bring someone with you. Not because you cannot manage the appointment alone, but because a second person in the room improves recall of what was discussed by a significant margin. They can ask the questions you forget to ask. They can remember the answers you might not retain under the mild stress of a medical conversation. And in the case of colonoscopy, you will need someone to drive you home anyway. Make it someone who will also remind you why you scheduled the appointment in the first place. Step 5. Tell someone else to go. After your appointment, after your screening, after you have the result that, in all probability, tells you that you are clear, tell a friend, a sibling, a neighbor who you know has been putting this off. Not with alarm, not with pressure, with the quiet authority of someone who has done the thing and can report back honestly that it was manageable, that it was worth it, and that the alternative is not worth considering. And before I close, a word that I will always include in every video I make, because it matters. Please do not alter any medication or ongoing treatment based on anything you have heard today. Cancer screening is a conversation with your medical team, not a replacement for one. Everything I have shared is designed to make you a more informed, more empowered participant in that conversation, not to substitute for the clinical judgment of the physicians who know your specific history. I want to end where we began. 2 neighbors, 1 decision. The difference in their stories was not luck. It was not genetics. It was not the particular cruelty or kindness of the universe. It was a single appointment, kept or not kept, at a time when keeping it still had the power to change everything. You are watching this video because some part of you understands that your health deserves attention. I am asking you to let that understanding become an action. One phone call, one appointment, one conversation with your doctor that you have been meaning to have for longer than you would like to admit. The best time to be screened was 5 years ago. The second best time is now. Down in the comments, I want to hear from you. Have you had a cancer screening that found something early, something you did not even know was there? Or have you been putting a screening off, and this video gave you the push you needed to schedule it? Share your story. You may not realize how many people watching this video needed to hear it. If someone you love is over 50 and has not had this conversation yet, share this video with them today. Not as a warning, as an act of care. And in the next video, I'm going to break down exactly what happens during each of the major screening procedures, step by step, from arrival to recovery, so that fear of the unknown is no longer a reason to delay. Make sure you are subscribed so you catch it when it comes out. I'm Dr. Alan Miller. Your life is worth looking after, and so is your screening schedule.